how do we actually work together to get better healthcare outcomes. This is not an experiment which is an unknown. Biggest opportunity around virtual wards is on the prevention of admission. Underestimate it at our peril. Can't suddenly turn this on. You've really got to think through. Some of that can be done at small scale. The system had become far more digitized within that period. Enlightening, scary, invigorating, fun. We know how to do this. We had over 400,000 people nationally going through a virtual ward.
Voices of Care, the healthcare podcast.
James, welcome to Voices of Care. It's really good to meet you in person.
Suhail, it's lovely to be here. Thank you.
Well, it's a transformational time, the NHS 10-year plan, NHS England changes. Also anniversary time, I think 15 years since CLCH formally got together. So
Yes.
Exciting for you.
Very exciting, very exciting. And I've been chief exec now for almost 3.5 years. So really, really good times.
And in terms of CLCH, if we can just get a broader picture,
Yep.
because I'm very familiar with the organisation for personal and professional reasons, as you know. It's spread on such a big geography, isn't it? Ealing, Hertfordshire. Can you give us a little bit of a snapshot? 14 London boroughs, something like
14 London boroughs and all of Hertfordshire. We provide 105 service lines across those areas, all the way from sexual health service and integrated family planning through children's developmental and universal services, working age adult services, frailty, end-of-life care and post-end-of-life care support.
And very much community-based provision.
All community-based provision. So we see around anywhere between 10 and 10,500 people a day across a variety of different sites and in their own homes.
In their own homes. And obviously this is a place where throughout your tenure and actually prior to that, it's been renowned for being quite innovative. I think you were one of the very first organisations to trailblaze with nursing associates, if I remember.
We are. So we have a really strong academy and really thinking through how do we support our local populations to join the National Health Service? How do we support that through both clinical training, non-clinical training, and becoming an anchor institution? I think that's important, especially if we think about where the 10-year plan might be heading around really developing neighbourhoods.
Yeah, and also you are also pioneers at, I know we're going to talk about that later, but hospital at home and virtual wards.
Yes, so to really support people at home and keep them at home in a safe way, we've been doing an awful lot of work with partners over many years, thinking through what that model of care looks like and how we integrate care across the primary care to acute sphere.
The NHS Confed recently produced a piece, a sprint around neighbourhood based care, place-based care. I think we should probably stay there for a second because you've been extraordinarily busy with your team in producing a new strategy. Can you tell us a little bit about that? So I think it's really fresh off the printing press.
It is.
That's not a very analogue way of describing it.
Well, no, it is. There is definitely going to be a paper-based copy of it and digital as well. So the strategy recognises the importance of place. And when we talk about place from a London and Hertfordshire context, we're talking about boroughs or districts and the county. And that's important because people live in the places in which they live. And the way we therefore develop integrated neighbourhoods is going to be based in those geographies. They're going to be real teams working with partners in support of our residents. There will be some service lines that are going to cut across maybe more than one place from a skill point of view or a resourcing point of view. But the direct focus is going to be about how do we actually work together to get better healthcare outcomes for our children and families and adults.
And the emphasis is very much on also tackling health inequality, but also boosting the broader mission of economic growth.
Yeah, so if you really want to think about health inequality and economic growth, a really good example of that are our MSK service, so musculoskeletal. We've got an awful lot of people in society who are not working because of that. How do we actually support people to get back to work and remain healthy? How do we, especially for people with long-term conditions, support them to retain their ability to work and be economically viable in our communities?
And I think one of the things that struck me from looking at the plans that you've got, and we can focus on them a little bit, is the idea of a 3-layered approach. Can you unpack that for me? Because it's not looking for what you're going to do right now. It's a much more longer term vision and being accountable. I think that's a big word that's come through.
There is quite a big accountability piece, but it's based on 3 types of changes and change methodologies: doing things well, doing things better, and doing better things. And if we sort of unpack that, doing things well is, how do we make sure that we are actually just delivering good care to everyone that we are working with? Doing things better is really starting to push the boundaries of, well, what more could we do to get better outcomes for our residents and our society? And doing better things is really starting to think through, how might we organise this in a fundamentally different way that meets the government's ambition around prevention, around digital healthcare, around delivering more services in the community? And a lot of that is going to be both as a leader and as a partner, but also maximising the skills of an engaged population to really think through, how do they support themselves in the delivery of a social healthcare contract.
And that's going to require, not putting words in your mouth, it's going to require a shift, not just the left shift that we've talked about, to community, but a rethink perhaps, or rebalancing in the way power and financial flows work, because the stats show over the recent years, despite many policy documents, 5-year forward view 11 years ago talked about this shift, but the percentage of the NHS budget going to acute care has actually been drifting up, whereas the budget going, I'm sure you're painfully aware of this, community care has been going the other way. So there's going to be some tension in how that works.
There is. So yes, we've had a proportional reduction in that spend, although recognising that the NHS, we have spent more in the NHS over years. So it's not I necessarily need more money, but it's the proportionality of what that spend looks like, which would result in more spend occurring in community services and in primary care services as well, and mental health. A part of that is us really thinking through not just the PowerPoint that you went to, but the accountability. And I think accountability looks very, very different in the non-hospital space. And part of that is, how do you therefore work with partners, specifically local government, in ensuring that we get the best for our residents? Some of that can be done at small scale around neighbourhoods, and some of it, if we really think through some of the digital transformation that might need to occur, that's more than just me as an organisation. That's me working with other partners in our sector to think through, what does that digital offer look like for organisations.
And that will cut across not just local authority, but dare I say, the integrated way of delivering social change, voluntary organisations and social care.
Yeah, so I have absolute regard for the voluntary and community sector, and we do an awful lot of work with the sector to promote better healthcare and better healthcare outcomes and a different way of engaging with our populations. And I see this as a real opportunity to strengthen that relationship, hence why the relationship with local government is important in that space, because they have a really strong commitment to that in all the places in which we work. But also the relationship then circling back to our GPs, our other primary care providers, our dentists, our pharmacists in the community, and really thinking through, how do we create a clearer healthcare model? And part of that is, I think, being much clearer around what is the offer to our residents, so that all of us fundamentally know, and we break this postcode lottery of the types of services people get. That doesn't mean that we won't be offering specific services in different communities, because some communities have very different needs, but we should all be getting the same outcomes in terms of our healthcare, and unfortunately that's not historically been the case.
And the final point, just wrapping around the context of it, we've obviously had spring statement, etc. Mr. Mackey has set a financial reset, £7 billion overspent, so there's going to be some little bit of alchemy that you're going to need to do in terms of meeting the budgetary requirements while delivering these aspirational services.
Yes. So I think the community sector is really interesting because the vast proportion of our contracts are on block. So just, I'm sure your listeners will understand it, but we get an annual settlement and we are to live within those means, which is very different to payment by results. So the sector has been very used to cost reduction and actually taking costs out of the system and maximising productivity. So I'm acutely aware of the cost per unit case of every single service line in my organisation, all 105. There are some improvements that we are making and continue to make, and there are other service lines that I actually think are probably as cost effective as anyone could possibly imagine. And that's where I think the conversation, tension and positive engagement is going to occur.
And there's potentially there, if I may say so, some hope, because if that shift to community where you are used to doing these annual settlements, perhaps offer some, I wouldn't say the solution to productivity, but probably some positive views around that.
Well, part of the solution to productivity, but also the solution to ensuring that the financial settlement is not overspent, which is a really important thing for all of us as taxpayers.
Great. Now, I wanted to delve into one particular aspect, and that's the virtual wards. You're a national lead advisor for virtual wards, but the context for this is the move into digitally enabled care at home. Set the scene about. I think everyone's heard the phrase, but if you look at different policy documents, there's slightly varied definitions. I would like you to unpack that. But the concept of hospital level type of care globally has been around since the 60s. But I think 2021, 2022, the government here put the formal policy behind that.
So 21, 22, we were in the middle of a pandemic.
Absolutely.
And we needed to provide as much care to people in their homes to prevent people going to hospital and save those beds for what was required at the time. We were fortunate that I think the system had become far more digitized within that period, and we were now in a very different place. Some of us had been doing this for quite a while. So this is not, as you've flagged, a new concept, but it was about putting resources where resources needed to be, because all of a sudden we had people at home. And there are really two distinct differences in virtual wards. The first of those virtual wards are wards that are on discharge, which is how do we get someone to be discharged safely home, to be cared for at home with technology, where they may not need care, they may need remote monitoring in some way, to give confidence to our acute colleagues that the patients aren't going to be readmitted, but more importantly, to give confidence to our residents, patients, families, that they are safe to be at home. I think that's really, really good. Yep. The vast proportion of people are actually wearing wearable technologies all the time, our phones, our watches.
Absolutely.
All of that. So those virtual wards were aimed to reduce the length of stay in hospital beds by 1 or 2 days, and that's really important in terms of elective recovery. But the biggest opportunity around virtual wards is on the prevention of admission for largely people with complex long-term conditions or frailty.
Yeah.
And this is something that's really a core plank of what we do in the community. We support an awful lot of people who are frail. And there's some really interesting statistics that, frail, largely older person who goes into hospital will take 30 steps a day in a hospital.
Right.
But when they're at home, when they're just as frail and unwell, they'll take 300 steps.
That's a dramatic
And that's
difference.
Dramatic difference. And, if you know any physios, that is a big difference. And our frail older population in going into hospital, we do need to support people in hospitals. Hospitals are the right places for some people. But the longer someone who's frail stays in hospital, the more likely it is that they will decondition, and the more likelihood is that they will need increased care. And that's something we need to prevent, not from just a financial point of view, but from an actual personal healthcare point of view. So if we can support people at home, they won't decondition as much, and they are more likely to remain well. And there's some really interesting work that we've been doing with some of our patients, and we're just about to launch a piece of research that looks at patient satisfaction, quite specifically around virtual wards. But one of our service users made a comment, which was, well, of course, if you're in a hospital bed in a shared ward, and the vast proportion of them are shared wards, in the middle of the night when all the lights are on or the bells are ringing, you don't get very much sleep. And it really struck it. It really brought it to a chord. Now, not everyone can be supported at home. Sometimes you do need to admit patients, but you also need to support that person to get back home as quickly as possible. And this is where putting the right resources in, the right nursing, therapeutic, pharmacy, medical support to support people at home becomes really important, enabled by technology, so that we can monitor that person robustly, but also bringing in care support through our local government partners and care agencies. And I think that all starts to alter the role of carers in society as well, as a very vital part of that offer.
No, absolutely. Thank you for setting that out, because I think that there's some confusion for people who are not absolutely experts. You've talked about, it's part of the goal of the policy clearly was financial, budgetary, reducing the pressure, of course, in hospitals. But it's also about patient choice, and there was a lot of stats and surveys done prior to this. There's quite a lot of public buy-in to the concept of virtual wards.
Yeah, so there's... if you've been on a virtual ward, or you've had a family member or friend on a virtual ward, you can completely understand it. You think it makes absolute sense. I do understand the reticence of people who've never been in a virtual ward, because it could be quite scary. But the vast proportion of our patients enjoy it, and from a national point of view, we've now delivered more than 12,800 virtual ward beds on a daily basis. And last year alone, so if we look at the 24-25 year, we had over 400,000 people nationally going through a virtual ward. So these are here, they're here to stay. We are going to need to consistently improve them, think through their occupancy, check that we're delivering the right sorts of care, but it's a very important plank of the way we are going to deliver neighbourhood care moving forward.
And looking at the impact of virtual wards, drawing on your own experience, perhaps we'll come into that in a bit more detail. So I think some really interesting work, I think led by Dr. Rochford at CLCH. But looking at the national picture with your national hat on, looking at the impact, are we able to see, is it too early in terms of the data? Because some of the research says that certain groups are underrepresented in virtual wards, whereas others say actually it has begun to make an impact in terms of the pressures on the system at an acute level.
So this is definitely a piece of development and live research. So if you do anything, and I'm sure your listeners will recognise this, you do something in 2021, 22 and say, we're going to start this. We believe it to be the right thing, both operationally and clinically, to deliver. That means you do need to allow people to experiment. And there have been virtual wards where I would say probably we haven't had the impact that we would have wanted.
Right.
There's been some virtual wards where the return on investment, the perception of service users is really quite significant, and it does go to that frailty offer. If you think through the other impact around skill development and bringing technology into the community, I don't think we would have progressed anywhere near as quickly as we have in terms of bringing new types of digital technology into the non-hospital space. We're looking at a piece of work with partners in Hertfordshire around how do we start to use the same type of digital technology across the totality of the healthcare sector, which I think is a really interesting and novel place to be. But it's also about how do we start to really think through what point of care testing would look like. And part of that is, pre-2021, my community nurses were not able to analyse bloods.
Right.
Through point of care testing. If you think through that productivity, a community nurse would go into someone's home, take bloods, hopefully get them to the lab in time for them to be read correctly. Turn around, and then the GP or the advanced nurse practitioner or therapist would then make a decision.
Well, how long would that take?
A day, two.
Right.
The likelihood is that frail older person would already be in hospital.
Right, okay.
Because they had actually deteriorated. Now, through point of care testing, for some tests, we can actually determine whether or not the patient is unwell, what we might actually do to inform new care. And there's been quite a debate about whether or not that point of care testing is as accurate as it could be. And it's not 100% accurate. I did challenge some colleagues about this, and I said, well, I'll tell you what's not 100% accurate is what we've already got.
Okay.
And us thinking through live change methodologies in the NHS is a really important factor in terms of delivering care, because we do need to make sure that we are constantly testing. And this goes back to the 3 pillars in our strategy. Doing things well, we should know what those things are. Doing things better, how do we really start to think through how can we make this better for care? Doing better things becomes really, really important. Really thinking through how we're going to transform the way health and care is delivered and received.
And it's interesting you talked about an experiment, and some of the numbers I've seen, I think some analysis of the Southeast region did point to savings, significant savings, over £10 million pounds in the Southeast. There was, I think, an outlier research, I think it was Ridlington, where it said it was twice the level of inpatient care, but actually that's been revised. But I wanted to centre in on the feedback that we've had from the users, the patients. We're beginning to see data where people are actually really embracing the opportunity to co-produce.
Agreed.
plans.
You know, we've got evidence of 98% of service users valuing virtual wards, and I think that is really, really important. Because you don't tend to see that sort of level of recommendation from being in a bed. And why would you? If you're unwell, becoming more unwell, you're not really feeling like you're getting better. But if we can keep people as well as possible, they're more likely to be having. That's a usual thing. I just want to circle back to one thing. It's about the experiment.
Yeah.
This is not an experiment which is an unknown position. I think we've got to be really clear with both our clinicians and our residents and partners and patients. This is based on clear historic evidence and actual worked live examples over significant periods of time. You know, I was running this with partners as a model in Barnet with colleagues at the Royal Free many years ago. So it's
trailblazer.
Well, no. I didn't even come up with it. Colleagues well before me came up with it, but it works, and it gives confidence to clinicians and leaders across the whole health and care spectrum, because as we start to build neighbourhood healthcare, what we've got to do is make sure that we are all collectively confident in a social healthcare model that we are getting the best outcomes that we can for our residents.
No, absolutely. And you've mentioned them several times, quite rightly, of course, and I think it's quite a big piece for our listeners and viewers, is the implications, some of the lessons for workforce. Now, we're at NHS 10-year plan, a revisiting of the long-term workforce plan. There's quite an inflection point for the NHS workforce. Can you just share some of the observations you've had? And then I want to look at some of the couple of your case studies, but the way that this has impacted the way multidisciplinary teams work and across the usual boundaries of health and social care.
So our workforce is by far our biggest asset, and we underestimate it at our peril in society. I have the fortune of leading an organisation where 82% of my workforce are women. The average age is 40, and she is more likely to be from the global majority. So 58% of the workforce is from the global majority. My biggest hope for my workforce is that they are proud of what they do and what they achieve working together for our patients. But that is about skill development.
Yep.
Really thinking through how do we support people who have been fortunate to be trained through university to develop their careers. More importantly, how do we support people through an anchor institution coming from communities to develop a career in social healthcare? How do we therefore engage with our workforce to work with partners, and particularly not just the statutory partners, so not just adult social care or GPs, but the voluntary sector, and really thinking through, well, what is that relationship with them? And therefore, I'd probably go to 3 points. It's about skill development.
Yep.
And those are teachable things. It's about confidence and us giving confidence as society to our health and care workers that they are valued and are able to deliver. And the third part is really around how do we teach new types of skills? Yep. And that's where I think the big digital step is going to take, because I'm not the best user of digital. I have a twin brother, and he's probably much better than me. He always has been at digital things. And we are going to need to teach people to do that. And that becomes important, because if our health and care workforce are more competent with digital, society is probably more competent with digital as well.
Absolutely. And there's been an embracing, I guess, from your feedback with your very early work in Hertfordshire, etc. I think the cohorts you work with frailty and also people with heart condition, I think.
So respiratory, heart conditions. I think we're going to be extending into end-of-life care more fully, because that's on the background of frailty. And
very topical at the moment.
Very, very topical. And part of this, and this is why not all virtual wards across the country are in the same space, because a lot of this has been about what resources do we already have that we might be able to shift, change, and develop. But you can't suddenly turn this on. You've really got to think through, what are the skills that I've got? How do we give confidence? What is the level of resource and capacity that we would have to be able to admit patients into those virtual wards and care for them? Because the last thing you want is to do harm.
Absolutely. There has been some coverage, going back to the point around the financial budgets, as I think the survey from NHS providers came out in May, showing that 47% of trust leaders, I'm sure you saw it, are going to potentially pare back some services. There was a hint that virtual wards may suffer. So I guess the evidence is going to be really important that this produces great return on investment.
Agreed. I think we're in a very challenged time. So I flagged before, I'm very aware of the cost per unit case of every single service line in the organisation. We have plans for further productivity measures, as your listeners would expect. But there does get a bit where a conversation is going to need to be had about what resources do we collectively have and where are we going to spend our money to get the best results that we can.
Absolutely. I'd like to end, if I may, to take a slightly bigger picture. This whole shift to community-based provision, prevention, and the role of leadership, because this comes up regularly. We've had Messenger reviews, the Hewitt review. Paint the picture of how important the role of integrated systems is going to be, and the role of the leaders within them, because to make this transformation real is going to require a big step change.
I think it's very different to run an organisation that works out of 736 sites than an organisation that runs out of one or two. And that's based upon ensuring you've got good processes in place to identify where there are risks or care is not being delivered in a way that one would expect. Very different processes and risk appetite around how I and my team develop not only the leaders in my organisation today, but give them accountability and ensure that they also don't trip up, and think about, well, who's going to be the next leader? And that we spend quite a lot of time really thinking through, how do we actually support those leadership teams to understand that and make sure that they understand their operating performance. And the third part is about, how do we work more consistently to rather than just describe the care that I'm delivering or we're delivering, but what that actually means for our residents. So through the lens of, I don't need to describe to my board about the care that we deliver. That's the day job. We need to move into a space of actually starting to describe more fully to our residents how they can be assured about the care that is being provided and the resource uses that would be needed to drive care forward. But in that, what that does mean is that we need to recognise that leading services across a partnership is very different to a command and control type of leadership. It's completely different skill set. And logistically, running an organisation over so many sites with so many patients on a daily basis is a completely different way of leading. And I sometimes say to colleagues or friends, I'm the chief exec of Central London Community Healthcare Trust. It's probably an organisation you've never heard of before, and on some level, I'm both disappointed that people don't recognise the historic value of community service, because I'm immensely proud of what we're able to deliver. But it's a good news story that no one needs to know, because it just kicks off in a usual way on a daily basis, and that I think is something to be really, really proud of through my leadership teams.
No, absolutely. One very final point, if I may, James. If we look at the big picture, the Health Foundation, I'm sure you're aware, has done a lot of work around where the health landscape will be in 2040. 9.1 million people with at least one major health condition. That's a 37% increase. The shift to community. I guess there's some positivity around anyone now, Mr. Starmer and the government have talked about increasing the attractiveness of health and social care. I guess the final point to you is this could be a really fabulous time for those considering a career in community-based care to deal with and support these changes that the society is facing.
So I historically worked in hospitals. My first jobs were in hospitals as a speech and language therapist. My first senior management job was in the community, and it was both enlightening, scary, invigorating, fun. It's a really, really different way of working. And if I was to ask any of my staff, I suspect that the vast proportion of them would say, it's tough, but you have so much more accountability. And at the end of the day, we have been doing community care for a very, very long time. I had the honour of being with some colleagues at the Queen's Nursing Institute the other day. And, our Queen's nurses, so our district nurses, our health visitors, have been delivering public health nursing for years, since the reign of Queen Victoria. We know how to do this. This is new in some way, but it's based upon a proper public health response to improving the life of our residents. And the original contract that the NHS had with the population in this country was about delivering services that were free at the point of care, that were close to home. And you can't get much closer when your district nurse is walking in, or your community physio, or your speech therapist, or your pharmacist, or your care support worker, when they're in your own home, helping you to remain well.
I think on that hopeful, historical and forward-looking note, I think there's a lot of excitement ahead and a lot of transition. James Benson, thank you for your time and for your insights.
Thank you.
It's been a pleasure. Thank you. If you've enjoyed this episode, please like, follow or subscribe wherever you receive your podcasts. And if you want to learn more about how we're really turning the dial on the health and social care debate, please visit newcrosshealthcare.com/voices of care. In the meantime, I'm Suhail Mirza. Thank you very much for joining us today, and I look forward to seeing you on the next episode. Thank you.
Voices of Care, the Healthcare Podcast.